Hello, this is Dr. Bhomik, and I'm going to discuss the second part of diabetes insipidus, and we discussed the first part other day. Now, the important thing in the second part is I will discuss some of the mimickers. They present with polyuria, polydipsia, but they are not diabetes. So we call them the diabetes mimicker. Then there is one is very interesting, at the same time could be very difficult to manage, and that's called psychogenic polydipsia, and that's the old name, psychogenic polydipsia, because it did occur with the people with neurodevelopmental delay, psychogenic disorder, but it has many other names also. I think those are more appropriate. So we'll talk about that when we go to that slide. Then the other one is nephrogenic diabetes insipidus, and then we'll discuss about therapy of central diabetes insipidus, therapy of nephrogenic diabetes insipidus, and psychogenic polydipsia. So the polyuria mimicking diabetes insipidus can be divided in three parts. One is the physiological suppression of ADAs, and that is a psychogenic or dipsogenic DI, diabetes insipidus, and the organic polydipsia. And genetically, the one condition that is interesting and that can make problem, especially in the newborn period, called nephrogenic DI. We'll talk a little bit about that. And the medullary cystic disease, where the kidney actually lose the concentration ability and the body produces diluted urine. And some pharmacological agent like lithium, diuretics, etc. The polyuria mimicking diabetes will also can happen in osmotic diuretics. The best example is diabetes mellitus. They will present with polyuria, polydipsia, weight loss, but that's because of diabetes mellitus. Electrolyte disturbances like hypercalcemia, hypokalemia can also give rise to some degree of polyuria. And the renal disease will be post-obstructive diuresis, renal tubular acidosis, pyelonephritis, and sickle cell disease. These are the polyuria here is not to the extent that you would like to you see normally in diabetes insipidus. And hyperthyroidism, where the patient's complaint could be they wake up at night quite a few times to go to restroom, which is rather new for this given patient. And the reason being is a hyperdynamic circulatory state. What I mean by that is that circulation in the kidney in hyperthyroidism, the blood supply of the kidney is increased as much as 10 to 13%, and increased blood supply means increased glomerular filtration and therefore increased urine output. Now, the one that I like to talk, because we are addressing mostly the pediatrics, one that is the one which I am more interested in because I am a pediatric endocrinologist. So, psychogenic polydipsia was the initial name, but that is a misnomer because in the beginning it was thought that this happens to the people or children who have psychiatric disorder, but it's really not. It is true that they may have psychiatric disorder, but there are other things. And so the term has been used like compulsive water drinking, dipsogenic polydipsia, primary polydipsia. And these conditions sometimes could be difficult to distinguish from diabetes insipidus. And antidiuretic hormone release is inhibited because of the persistent hypoosmolality. The key finding, and this is most important thing to remember, that since there is a hemodilution because of the excessive water drinking, electrolyte wise sodium level will be low, there will be hyponatremia, hypoosmolality at random serum sample, which is completely opposite to either nephrogenic diabetes insipidus or central diabetes insipidus. Prolonged water deprivation test may be necessary to diagnose, and there is washout effect can make it difficult. The treatment consists of water restriction, psychological counseling. We have seen this condition in toddler or children less than 3-4 years of age that occurs suddenly when there is a birth of the second child, or mother has got a new job, and in the military we used to see that when father is deployed overseas. So those are the history one need to take and get to find out that what was the etiology of this condition in that particular case. Now, I want to talk to you about the nephrogenic DI. This nephrogenic DI, also known as pitrasin-resistant diabetes insipidus, and this is X-linked recessive. Now, I like to tell you a little story, but this is the history that I read when I was reading about nephrogenic DI. So the story goes like this. Long time ago, the Canadian province of Nova Scotia, a group of gypsies were passing by, and that time there is no water supply anywhere excepting that you get your water from the water hole or water oil. And so many of the people, they own water hole and then the other people shares. So one gypsy mother came to a group of ladies who were fetching water from the water well and begged some water for her son, who was very thirsty. As you know that time or even today, the gypsies are not treated very with a lot of respect, And so these ladies refusing to give her son any water. In fact, they are also giving water and then pouring on the ground. They are just like us playing and with this child thirst mechanism. So the gypsy mother was very upset, and she raised her hand to the sun god and give all these ladies a curse, saying that this woman did not give water to my son in the face of excessive thirst, and their cruelty will be punished by the sun god. And how that will happen? These ladies, their children as they will be born, and if they are male, they will suffer from the excessive thirst, and even in the plethora of water, their thirst will not be quenched. And so this is called gypsy mother's curse, and since it will only affect the male child, and therefore it is excellent. So, but what is the bottom line is that the renal tubular does not respond to ADAs, and ADA's level, if you measure indeed, will be somewhat higher, and its male siblings are affected, and this is actually carry the high mortality and morbidity, because the disease, this condition manifests from the newborn period or even in the nursery, in the infancy. So there is repeated hypernatremia, dehydration, and the brain injury. Clinical findings is the polyuria polydipsia, just like DI, very irritable, and they prefer water over any other fluid, unexplained fever, failure to thrive, and episodic hypernatremia, as I have mentioned, and the mental retardation and constipation. If you do the laboratory test, that serum electrolyte will be very similar like central DI, borderline or clear hypernatremia, and osmolarity will be high, serum osmolarity, and administration of ADAs will fail to suppress polyuria. And if you do the radiological or ultrasound, you see the dilated ureter calyxes and the bladder, because they hold lot more water, urine, than they normally do, normal children do. And sometimes it might mimic like GU obstruction. And therapy for nephrogenic DI is more difficult, and because of the age, especially in infancy, liberal water intake, breastfeeding with low salt, and a low protein diet is preferable, and the medicine that has been used, chlorothiazide or hydrochlorothiazide, which is about 10 times more potent. The former is 30 milligram per kg per day, and the hydrochlorothiazide is 3 milligram per kg per day, divided in about 3 times a day. And some people feel the indomethacin may have some additive effect. Actually, this form of therapy can be used in central DI during infancy. The reason the chlorothiazide or hydrochlorothiazide work is when you give chlorothiazide or hydrochlorothiazide, what it actually does is shift the sodium absorption from distal convoluted tubule to the proximal tubule. And as you know that as the sodium get absorbed, it absorbed with water. So basically what we do, we shift the absorption of sodium from distal to proximal and also absorb water with the sodium, which is ADAs non-dependent, which is not ADAs dependent. So therefore, less amount of water is going to be will be presented to the distal convoluted tubule and distal nephron, where is the site of ADAs action. Hormone replacement therapy obviously is once diagnosis is going to be done by the pediatric endocrinologist, and the long acting is called DDAVP, and the dose is there, but the dose has to be adjusted. Even the frequency, normally 2 times a day should be okay, sometimes 3 times a day, so you have to adjust accordingly. When it comes to the central DI, I just want to emphasize, in central DI, many a times the etiology may not be clear at the time of diagnosis. A neurological examination is of utmost importance. If necessary, a neurologist may not be a bad idea to have a neurologist examine this patient. MRI of the brain is a must, and it may have to be repeated in 6 months to 1 year or even 2 years, after 2 years also, up to 2 years, 2 to 3 years, because sometimes the tumor may be small enough and may go undetected, and so it has to be, one has to be very careful, especially followed by the MRI, to make sure that they are not missing any tumor or lesion in central nervous system. Now, the fast acting one is lysine vasopressin, and this is safe in the sense that it has short action, period of action, and therefore overdose and water retention and hemodilation is less of a problem, and it is especially suitable for infant. And dose has to be adjusted and carefully followed by endocrinologist. Diet of diabetes insipidus is pretty same for NDI or central DI. Low salt is uniformly prescribed and usually less than 0.7 milliequivalent per kg per day, as well as low protein diet, which should be less than a gram per day, per kg per day, and work best for the infant with DI as well as nephrogenic diabetes insipidus. Thank you very much for your attention, and hopefully this will give you some idea And I like to emphasize that, remember, the genetic mechanism of transmission of nephrogenic DI is X-linked recessive, and it is a resistant thing. And psychogenic polydipsia, the one that you really, a serum electrolyte is very helpful if you have a hyponatremia in the face of polyuria polydipsia, that makes the diagnosis of any form of DI very unlikely.